Good morning and welcome to our monthly live broadcast of peripheral endovascular cases from Mount Sinai Hospital here in New York City. I'm your moderator, Vishal Kapoor. And as our monthly protocol, we're going to be presenting another very exciting case, this time with Dr. Christian and Dr. Raman Sharma in the OR cath lab room. Before we go into PK, just wanted to do some home chores. As always, please go to our website, www.ccclivecases.org, for our previous archived cases, which is under the peripheral intervention tab. You can see this case as well by the end of the week. For any questions, concerns, you can email us or you can put on the comment section, and we'll be more than happy to interact and reply as soon as possible. So without further ado, good morning, PK. Good morning, Raman.
How are you?
Good.
Can you hear us?
Yes, we can hear you now.
Okay, good. Okay, I just wanted to welcome all the viewers back to our cath lab. Today we have a very exciting case. Dr. Sharma's clinic patient has been kind enough to agree to so he can participate in teaching all of us the patient. Behind me is Ray Lascano, our interventional nurse practitioner. Obviously, everybody now knows Dr. Sharma, who's in front of me. Next to him is Twinkle Singh, who's our endovascular fellow. We have Jen, and we have Liz, and we have Cameron, and we have Damien, all of them here to help us. And now we are ready to get started with this exciting case, which really is going to involve a lot of decision making. We need a lot of your help and Dr. Guja's help, and then we'll get going. Go ahead with the presentation.
Can you pull up the slides?
Yep, that's definitely it.
Good morning, Raman.
Okay.
Morning, Dr. Guja.
Hi, good morning, everyone. So the case is a 66-year-old male with past medical history of diabetes, hypertension, hyperlipidemia, now presents with continued bilateral lifestyle-limiting claudication in right leg more than left with Rutherford class 2 category 3, despite maximum medical therapy. He is on amlodipine, aspirin, Lipitor, cilostazol, glipizide, and metformin, but continues to have symptoms. His pertinent labs are pertinent for hemoglobin of 11.4, creatinine 1.3, and INR of 0.9. ABI is on the right side at rest showed 0.56 and left normal at 0.9. With exercise, right side ABI dropped to 0.1 and with left remained normal. Arterial duplex was done that showed occluded right SFA from proximal to distal thigh with reconstitution at popliteal, occluded mid to distal popliteal, occluded peroneal and TP trunk, and patent AT and PT. So the angiogram on the left side, as you see, mild moderate SFA disease, some AT disease there, but 3-vessel runoff. On the right side, I see the occlusion, the proximal SFA. Then it reconstitutes at the distal level. Then occludes again at the popliteal and reconstitutes at the trifurcation level, as you see on this side. Just before the bifurcation of AT and TP trunk. And the foot shot shows a good 2 to 3 vessel runoff.
So Raman, clinically, how is he? I mean, clinically, tell me about his condition clinically.
So he's had actually symptoms for quite some time now. He was recently unable to have consistent access to medical care, and only recently he was able to reestablish his medical care with his primary care doctor, myself and everybody. And his most common presenting complaint to everybody was originally just leg pain, and he would have this originally with on ambulation 1 to 2 blocks, always improving with rest. Well, over the course of the past few months of us interacting, he's really described a syndrome that almost has progressed to even at rest. Yeah, and initially after the non-invasive testing, it really was very classical claudication symptoms, and and exercise ABI to 0.1 is quite impressive. And he, like a lot of our patients, was given the cilostazol, but it's a very challenging medication, and it's very difficult for people to really tolerate that. He did his absolute best, but despite all these, our attempts and the adequate titrations, he was not really able to. So that's what eventually brought him here.
So when you look at the angiogram, guys, I think a lot of interesting stuff for. Well, I want to know. Obviously, you have an occluded SFA, which we already started crossing. The only interesting thing about the SFA is you have an ambiguous cap that Raman and I noticed. You can see here it's coming off. You think that's a profunda, it's not. It's really the proximal SFA with a weird type of cap. The reason we know that is because if you follow the calcium, you could see the calcium is following where our fielder wire is,
right.
and then you can go ahead and orient yourself. So that's definitely the SFA cap. The other thing is also when you look, here's another picture from above, and you can see the cap is pretty ambiguous, and here you're not sure where you are. That looks like a profunda or a bad profunda. The reality is he has a very robust profunda. So that's really not the profunda. But I think more importantly is the idea in terms of the trifurcation. And, I think that's
Dr.
the
Kakar,
picture.
this is Jake from Medinbox. If you can go ahead and unmute yourself and unmute your video.
Unmute myself.
No, Dr. Kukar.
Oh, Dr. Kukar. Okay.
Yeah.
So I think that, if you can play the run on the trifurcation, Raman, you could see. So it creates a lot of confusion in terms of how to treat. Yes, he's rest pain. So if he's rest pain and truly CLI, I mean, is he a bypass candidate? Well, it's going to be a long fem below knee bypass, right? So it's and the reality is he has good runoff, but you're really going to have to either hit the AT or the Fem AT is probably the right bypass,
Right.
or the Fem PT, and then retrograde filling. So what we thought was, if we can, Raman and I spoke about this yesterday, if we can do this without disrupting the trifurcation, really preserving the AT and the perineal and the PT, we'd be okay. So I just want to tell you our thoughts. What we talked about was getting wire access in the AT or the PT, and either Raman wanted to cross protect the AT from the other side, meaning so we got posterior tibial access and put the wire into the AT, which we're going to do in a second when we get there, and then cross from above into the perineal, and then obviously do balloon angioplasty above and wire protected on this side. The other thing you could do is obviously external cross from below, externalize the wire. So I'm curious to see what you're thinking. But first, we need to cross the SFA. So while you guys are talking, I'll cross the SFA with Raman.
Yeah, I mean, it's a very impressive lesion, and like Raman was talking about, the exercise ABO 0.1 is very, very critical. I mean, he's almost impinging his, compromising his leg off. Pretty impressive 3-vessel runoff at the end, that's for sure. So I think you're right. I mean, it's more than a one-step simple strategy. We probably, like you did, you have to get access from both the ends and try to connect the dots. I guess the biggest limiting factor, which I guess Karthik will agree, is first crossing the SFA and then trying to be interluminal, because it's like an island and then again a lesion. So we have to try to make sure.
Yeah. So I agree, PK. I think it's but I mean, because you already have below knee access, PK, I think it might be better to cross. You'll probably be easily able to cross, not easily, but reasonably easily be able to cross into the popliteal from below first, than actually this long SFA CTO, because you look pretty subintimal here.
Yeah.
So and you're really going on the vessel. So once you get into the popliteal, you might be able to get the catheter from below, and you might have a better chance getting into this plane instead of making a long subintimal plane.
Yeah.
I agree, but the problem is we already
committed
committed to the plane, so I'm just going to go
finish
it off.
I mean, Karthik's, I guess, point is where to meet up. Like
way to meet up the.
I think we're not gonna extend it past the reconstitution zone. That's for sure.
Right.
And we can always go with a crossing catheter here. Look out, Ray, for a second.
Also, what would be your
compared to the other side, it was also we also saw that he does have what's like almost like seminole vessels on both sides of the SFA. So it seemed as if the plane may be very, very big, but I think the vessels are bigger,
very close by.
To think. So I think we may be, making reasonable progress here.
Right. Atul, your thoughts? We can't hear you. Atul, you have to unmute yourself. Sorry.
Thanks. Sorry, I just had a little technical problem this morning. I think the key is where. Can't hear me?
Yeah, we can hear you. Yeah.
No, actually, I kind of want to.
It's like you're saying, where do you join, or where do you connect the dots? And I think the dot connecting has to be in a safe area, and that's probably an area you're going to have to stent. So you want to connect in an area where you can feel more comfortable placing the stent.
Not going.
Right.
I
mean, I think that's the problem.
Probably.
I think we entered it, right?
Yeah,
Nice.
We're good.
That's very nice.
Take you off. 1 second. I just.
Let's get some speed.
Floral
Just
save something.
rail me, Flora.
So I think yeah, that's a good start beginning because
Make
now
sure I
you're
get some
back
speed.
into your regular lumen of the vessel.
Yeah.
Yeah, I gotta watch.
So even
where
if you
I
want to
gotta come
connect
back.
with your
Yeah, let the
posterior
wire
tibial
go.
wire in that zone or area, I think that'll be
Let the
very
wire go.
It'll be
favorable.
easy to do. Yeah.
And
And we
we
can
won't have
externalize the wire from
Correct.
here if we have to.
the idea is
Let the
like
wire
we
go
were
forward.
like PK and Karthik was talking about is not
You have a
disrupting the
dry douse, please?
trifurcation because
Yeah.
the distal
Yeah.
vessel
No, not good.
vessel runoff is
All right, nav it
beautiful.
cross,
Really
guys. Okay, off-road map. Ready, show me a sheet, please, from above. So yeah, when we're pushing, we're having trouble. We want to make sure we didn't move the sheet, which we didn't, which is good. Show me the distal wire.
I mean, it looks great.
Looks very good. Nice.
Yeah, I mean, at this stage, I mean, we knew. I mean, all of us can cross this without a problem. So we knew that it's not going to be an
Yeah.
issue to cross.
I
It's
don't
just
know
a
all of
question
us
of
can do it, but yes, you
Watch
did
a
very
little more out.
seemingly easily. So
No, I
Yeah.
mean, all of. I
I
mean,
mean,
I mean,
the
honestly,
interesting thing is
So I-
what do we do at the next level?
Yeah, the question
that's-
is that the reason we're
that's-
presenting this case is for the next level. Exactly.
So
You
what?
know, the trifurcation.
Right. So I mean, there could be again, like you said, multiple approaches. Do you want to? You already have an O14 wire down. You're intraluminal in that segment of the vessel. If you want to keep continuing down and hopefully you stay in the plane, you might be able to connect from top. But like I said, I would not be super aggressive enough to upscale my wire to an 035. I'll just keep it to an O14, O18 system. And if you're not able to connect, then we start
Agreed.
poking. We already have access
More
from
wire.
below.
Mhm.
So like we
wire.
talk about preserving that beautiful 3-vessel runoff he has. I think that would be the strategy, is try to have a feeler from top and just keep going. If
You
you
got it.
connect, great.
Almost.
But
Yeah.
if not,
Okay. Go
just
Got it.
reverse is as good as it gets.
Yeah, I mean, I think the goal has to be to preserve the runoff
Right.
and try to not be too subintimal in the pop and end up with a large stent. Go all the way in, right?
No,
Yeah.
So
Good, that's
one of
perfect.
our viewers
Second.
wants to know, PK and Raman, is if let's say we were still subintimal in that island or zone of your lumen, would you try to re-enter first back in, or would you keep continuing and dissecting your plane down all the way distal into the pop? You know, we
I
have
think you
re-entry
definitely have
devices.
to oblige yourself
Yeah.
to enter distally first into the true lumen,
Mhm.
because then you'll have to be concerned about actually the amount of support you'll need to then cross the second CTO segment if you don't have an area where you're actually intimal.
Start from-
Or sorry,
Right.
sorry, not your true luminal. Apologies.
So now we're
Yeah.
true luminal, guys. I'm going to take your advice and start from below.
Now
And let-
here's
and so-
here's another question. What do you get? What do you PK? What do you think about treating the SFA entirely first, and then from here, and then working from below simultaneously?
Well, I think for sure you're going to be able to. What is it called? Go ahead. I know for sure you're going to be able to treat the SFA, right? You already have access, right? So don't move, sir. I'm just going to give a little. Are you okay? You had any pain? Give a little roadmap for Raman.
that's a good spot where Raman is.
Yeah, it's a very good spot. I just want to go ahead and give him roadmap.
I think
so
we're in
this
a
So-
little bit of a plan. Can we all get a
ready,
comprehensive,
roadmap?
please?
way, once off floor.
So just for the
Sure.
viewers, Raman, for the pedal access, what do you have down there? Do you just have a support
So
catheter? Do
we
you
have
have
a-
a sheath?
Please.
We have a
Laura?
no sheath. We just have a CXI and a V18 wire that we're probably going to exchange out pretty
Yeah,
soon.
the collateral.
Yeah, probably.
Do you have
for
a micro
Confianza.
catheter? Right.
I don't. Does that collateral go there? I don't think so.
I don't think so.
I don't think, so.
think
Try to
he's in a
go with it.
collateral. He
Yeah, I
could-
agree.
he
I
could
agree.
do
It's just overlapping. Flora?
It's just an
It looks
overlap.
like the distal cap. So
Yep, see? Yeah, there you go. Fix it.
So Atul, for
Let me
you,
give you a
from
catheter.
your approach, do you think going sheathless
Just
in
slow
this
down. Fix
case
it now. Don't let it
and
buckle.
having not much support versus putting a short cook sheath and giving it support, what's your strategy? What's your preference?
I always try to go
Moving
sheath.
forward.
Rail
I
to
think putting the sheath in is a lot of spasm down there. So try it first. If you don't have the support and you find yourself buckling a lot, then you can always throw a sheath in later. But sometimes you get lucky and go right through.
Right. I mean, yeah, here
Laura?
most of the times if the goal is to try to do everything anti-grade, meaning like from top down, then I guess going by sheathless is a better
Okay.
option. Unless your primary goal is to
Mhm.
fix everything from below, then probably sheath is definitely needed. So I think it's just depending on the strategy of what
it's a
strategy you have.
3-vessel runoff. I think
Yeah,
you
and it's
have
a good sized
support.
vessel. Oh, he moved.
He moves.
Okay.
You
Well, they're almost.
PK, you might want to want to give it just from above and see, like just from the catheter, because
Yeah, it's a
all
good
you want to
idea.
see.
Yeah, I
That's a
think
good
we're
idea.
gonna.
Because he's going to move, right? So
Yeah. The only questions are about how much of the distal vessel we're going to actually see if we inject
Yeah,
just up
that's
top.
good right there.
That's
I
good.
think you need to go a little more medial, I guess.
Yeah.
Flora?
Probably should change to a.
So you
Yeah,
have a
I think one of the-
Confianza wire
one
right
of
now?
Yeah.
Yeah,
One of
you're
the
gonna
big
go
keys
with
is
it.
taking the
Can we get a
multiple views.
Confianza, please? Okay.
rotating the camera around the popliteal will help a lot to make sure you're going the right way, which I think you guys are doing very well right now.
Off-road map?
Right. I mean, here the CTO or the occlusion is very blunt.
PK
so that's
would,
why people stop.
because there is, you can see the cap proximally. Would you poke from the top and see if you can touch, if we can connect both the dots, or?
Yeah.
Yeah, guys, we need some help here, please. Okay, he's moving way too much. No, I understand.
Thank you.
Okay. The problem is from up top, Karthik, is a big collateral.
Yeah.
It's not a favorable cap for us. I'm going to try to probe it now with the catheter as Raman comes, but it's not a very favorable. There's a lot of tension
In the
above.
catheter itself.
Yeah,
Because we haven't ballooned the
proximal
track.
occlusion.
Yeah.
Correct.
We haven't ballooned the track. I mean, I could balloon the track and then take it. Give me a wire, guys. Give me a woolly wire.
No, I would primarily go from the bottom where Raman is coming from, get a directionality of where the spot proximally might be, and then worst case, if you're in the subintimal plane from below, you can start to poke towards the wire on the other that
Yeah,
side.
that's why I pulled the
and
wire
then try
back,
to
because
connect.
I thought he was committed to a
Correct.
plane, so I just pulled the wire back slightly, and then we'll go forward like this. And Ray will
So from
do well. That looks
anticoagulation
a lot better
strat-
to me.
That's a
That
lot
looks
better
a lot better.
direction. Lot better
That's-
direction.
Yeah. Yep. Now let me just come to another side now.
So what anticoagulation strategy are we using here? Heparin
Right
or
now,
Angiomax?
all we're using is Angiomax as we
Angiomax.
always do, because of these live cases. It definitely becomes. how can
Also,
you
it's a
say it?
long case.
Exactly.
Angiomax is better. We don't have to keep tracking.
Yeah, exactly. So I'm just trying to get this down closer, like you said. Okay, we're down closer now. Now let me give Robinson a dive from above, and this way I can
I
puff
don't
it
like
out.
how that turned.
Yeah, I don't like that turn either. So we'll try
Yeah.
from above too. So,
No, but I think PK's, I think PK's catheter might be directing towards the collateral actually.
give me a little dive, please, Twinkle. More. Okay, good. No, I think you're going off, Roman. I think so. Let's take a. Okay, he's gonna move now. Let him move. See, yeah, I think you're. Unless you're
A little bit
crossed,
off.
unless the wire is moving smoothly.
No,
You
I don't
yeah,
think it is.
No.
I
It's
think
moving pretty smooth though. Let me see.
Really?
No. Well,
No,
it's
it
mo-
doesn't.
no, it stops.
Yeah.
So pull back and try to find another plane. Let me torque the catheter up here.
Maybe you want to get your microcatheter a little bit higher up,
Yeah,
Raman,
exactly.
to give you a little bit of more directionality.
Okay, give
This
me a
I
wire
like.
from top, guys. Let me try from top. Mm-hmm. Mm-hmm.
Yeah, I think that support will help you. Now you can probably,
that's
Give a
better.
roadmap, Ray, for him.
That's definitely better.
yeah, it's less deviating and more,
Ready,
a
Ray?
little bit more centralized.
1 second, Ron. We still came off
Yep.
floor. Roadmap. Mm-hmm. Inject. Wonderful. It's okay.
Love
let
it.
move.
Beautiful design, PK.
Hey,
Oh, there we go. I think roadmap is,
It's not gonna work here.
yeah.
I think you might be through, Roman.
No,
No,
I don't know.
No,
I don't like how that's
have to
turned.
point
If I can
the
just
other-
turn left, that'll probably be what I need.
what wire is that, Raman? Confianza?
Confianza again.
Yeah, maybe you need a little bit different bend on it, I guess. So that
Or
might
maybe
just-
take a little, maybe try a different angle. Turn your eye a little, 89 degrees away from where you are right now.
Yeah.
I'm gonna touch.
Yeah.
I think it's
Right.
harder for PK to find the lumen. I think Raman would be
That's
the.
a good one.
a
Raman.
collateral.
That looks very nice.
Yeah, that sounds like
No, no, I
PK for
think,
you. Will be hard.
Raman's looks much better.
Better,
Yeah,
yeah. This is a little bit better now. Let's curve around too much.
Yeah.
Hold the sheath for 1
That's
second.
a good spot, PK.
I know that's what I'm trying there. Nope. Nope.
Oh, that's nice.
Nope.
The collateral again.
Yeah, it's a
Yeah.
big collateral.
Okay, what wire do you have coming from above?
Just a Confianza.
Okay.
I mean, I think we have to try with different wire from below. Let's
Just change the curve a little bit on the
Yeah,
Confianza.
but I think a little bit more weight on your wire, Raman, would probably try
Yeah.
to break through the plane,
Yeah, let's
and
get
it will give you a support as well
yeah,
through the
Ostado.
microcatheter. Yeah, let's get an Ostado like a.
Asada will be good.
30. But yet, do you have an 014 or an 018 from
014.
underneath?
Where's contrast?
Oh,
Yeah,
wow.
we have
Then
a
that's
we have
tough.
a 018.
Oh, then it's good because then you
Yeah.
can get your 018 system wires up there as well, like in a start of 30, 40. But I think a little bit more heavier weight wire will help you.
Oh,
PK, what if you go from the other
Yeah,
side of the
that's fine.
collateral? See, the collateral is coming from one
That's
end.
what I'm trying to do. Give me a.
If you want to take a micro catheter and, like you
yeah,
said, put it
that's,
into
give me a
the
woolly wire. Yeah, that's what I'm trying.
yeah.
I can see it now. I couldn't understand it before.
Now it's
Yeah,
a little
give-
bit better. That's
yeah,
all.
Yep.
So that other beak from the other side, and you jam your
Mhm.
catheter, and will probably.
So
Be
while they're trying to cross here, let me be devil's advocate. Why not just fix the SFA, increase the pressure head to your collaterals to below the knee vessels, and have a borderline CLI, but really a claudicant? What if you get away with just opening everything up from above and leaving the pop CTO?
Yeah, I definitely think that's reasonable, Art. I definitely do. Right, push
Well,
this
well, the
catheter down.
question is, what's? I mean, I guess we don't know the data on the
Mhm.
long-term patency when you have not a real one inline flow
Go
in
down,
your
right?
collaterals. The question is, would you
More.
be comfortable
More.
putting in
Go all the way
stents
down.
if you have to? I mean, most
More.
of the times what you'll do is you can do a PTA, a drug-coated balloon, increase the luminal gain, and then
Just,
improve the inflow, improve the
Mr. Ward
symptoms,
is up.
and bring them back to
fell in.
stage it, which you could if you
Go
fail.
back.
But I don't know how comfortable would you, Karthik, how comfortable would
I
you
will
putting a
not
stent?
put a stent unless I have an outflow. I never stent a vessel.
Yeah.
So I agree. I would never
Even
put
though
a
it might be
covered
from,
but anything that's not a covered stent with this kind of outflow and with
yeah.
the island of a good, an island.
My catheter.
I don't know.
It
Atul,
looks
I'm
like a
not-
prominent
that's a
collateral,
good
but
one. That's a good one, PK.
Yeah.
Even if you
Yeah,
have
but
to dissect a little bit there, I think it's still okay.
Yeah,
if
I'm
you
gonna
get
need
the
a
cap.
glide wire. I don't want to lose this collateral though, guys. That's why
I
I'm gonna
don't think
cross.
you will. I don't think that's
Yeah, it's so. I think
because
we'd
I
be able
think
to
the
cross this
cap
from above.
is beyond the collateral, don't you think?
Yeah.
Okay.
It's
Yeah,
behind it.
I understand,
behind
but
it?
I think if we go with the dissection plate, rail you are. If we go with the dissection plate, I think what's gonna I got it. I'll push it off here.
But I think you're dissecting after the collateral. It's a pretty significant angle, right? I think that angle is not going to destroy the collateral.
Oh, I agree. I agree with you.
Yeah.
Here, let's try a Terumo M wire, guys. Give me an M. Go give it to Raman, and that'll cross. I think.
So you tried the Confianza BK, it didn't go?
Well, I haven't tried it. Raman is trying it. It's not going, obviously. So I think that I think it's there. See, now you're not on the right plane.
That's
Nope,
a
I think
big
we're in the
plane we
wrong plane.
created there. So
So I
Yeah.
think PK, you could use a Confianza from top and then try to poke that way, and it's going to fly.
I think there's so much resistance from up top. We're gonna have to
Okay.
balloon the SFA first.
Yeah.
yeah,
We're gonna have to.
I think
So
that's
we
There's
will.
nothing wrong.
We will,
Yeah.
but we just want to. I think
Get a feel of it.
Yeah. Let me just get a feel from below.
Yeah.
You want the
Let me try with this wire.
you want the Stato maybe?
No, I think this. Yeah, a shot is fine. A shot is fine. Let me just get a feel.
Yeah.
So in the meantime, we've asked Twinkle, while Raman and I watch paint dry here, is going to go ahead and make them. He's done an incredible presentation for you guys about dealing with below knee disease. As always, she's been doing a great job all year. So Twinkle, while we struggle here, maybe you can, the audience would appreciate you educating them. So and us.
Yeah.
So please. Mm-hmm. Go ahead.
The slides. Oh,
Sorry, guys.
Got it.
No, it's just tangled on itself.
okay.
Slides?
So this is basically a review
Okay, it's
about endovascular therapies that are currently available for below the knee
I
vessels.
would just attach some dye to that
POVA,
side, right?
that's the most
Yeah.
commonly used. But the downside of POVA is very poor patency of 30 to 50% at 1 year. Vessels tend to have elastic recoil, dissection, and that limits the rate of technical success. Drug-eluting balloons, they've been studied, but RCTs have failed to, and there are no currently approved DCBs in US for below the knee. They're balloon expandable drug-eluting stents. They do have reduced rate of restenosis and have better patency. However, there is currently no on-label dedicated BTK stent as of now in the market. Okay. So for drug-eluting balloons and below the knee, Lutonix and Impact Deep are the two major randomized trials, and a short BioLux 2. So Lutonix BTK trial studied a paclitaxel-coated balloon 2 to 4 mm in diameter and lengths of 40 to 150 mm across United States, Europe, and Japan. They randomized 380 patients to DCB arm and 225 patients to PTA with a mean lesion length of 111 mm in DCB and 94 in PTA arm. They had significant number of patients with complete occlusion, 37% in DCB and 35% in PTA, and severely calcified lesions as well, about 59% in DCB and 54% in PTA. Their primary endpoints at 6 months, the safety outcomes showed that DCB was non-inferior to PTA. However, the primary efficacy point, which was a composite of primary patency and limb salvage, that DCB arm had 10% higher outcomes compared to the PTA. However, that did not meet the statistical significance criteria. When this same population was followed up for 3 years, there was no difference in freedom from all-cause death. There's no difference in amputation-free survival with 77% in both the arms. And so the overall summary of this trial that at 3 years, safety is comparable between the two groups. There is no difference in all-cause death, major amputation, or amputation-free survival. And the 3-year efficacy, there is no statistical difference between the two groups. So Lutonix BTK was preceded by this smaller trial studying Lux drug-releasing PTA balloon. It was a prospective multi-center randomized trial of 72 patients with 36 patients randomized to DCB and 36 to PTA, followed up to 1, 6, and 12 months. So similar results, the primary safety, probably due to low number of patients, primary safety endpoint, which was a composite of all-cause mortality, target extremity, major amputation, target lesion thrombosis, and target vessel revascularization at 30 days, was not different in two groups. And similarly, primary performance endpoint, which was patency loss at 6 months, was also not different in two groups, not statistically different. So the Impact Deep trial, their 5-year outcomes were published in 2020, JAG Interventions. Impact Deep was a prospective multi-center patient-blinded randomized controlled trial of Impact Amphibian DCB versus PTA. They studied 358 patients across 13 European sites from September 2009 to July 2012. At 5 years, they had 95 patients left in DCB and 49 patients in PTA group that could complete the 5-year follow-up. So they showed that at 5 years, their primary efficacy endpoint, which was freedom from clinically driven target lesion revasc, was actually lower in Impact Amphibian arm compared to the PTA, although it was not statistically significant. Similarly, there was no difference in freedom from all-cause death at 5 years with Impact Deep, and there was no difference in freedom from major amputation in both DCB and PTA arms at 5 years. So now coming back, looking at evidence for DES in Fem-Popliteal vessels, there have been 4 major trials, mainly Achilles, Yukon, BTK, Destiny, and Paddy Van Overgan et al. The Biolux is it, yeah. Okay. Yukon BTK trial, it studied 161 patients, randomized to 82 in sirolimus eluting stent and 79 to bare metal stent, and they followed the patients up to 12 months. 62 patients remained in sirolimus eluting stent trial and arm, and 63 in bare metal stent arm. So their target lesion characteristics were significant for a reference vessel diameter of 3.0 in both the arms. Lesions were focal, length of lesion 30 mm in both the arms. So Yukon BTK showed that at 1 year, primary and both secondary patency was significantly higher in sirolimus eluting stent arm compared to the bare metal stent arm. They also showed that Rutherford classification at 12 months, there was an improvement by more than one class and significantly in the sirolimus group compared to the bare metal stent group. So they also showed that by 12 months, the number of patients with a lower Rutherford class kept increasing significantly in sirolimus arm compared to the bare metal. However, at 12 months, the event-free survival rate was not different between the two arms. However, when the same patient population was followed up long-term for 3 years, the curve between sirolimus eluting stent and bare metal eluting stent, they continue to diverge and favoring sirolimus eluting stent. And overall event-free survival increases, becomes statistically significant at 3 years. However, only in the CLI patient population, the arm with there is no statistical significance difference between sirolimus eluting stent arm and the bare metal. The Destiny study in 2011, they studied also a difference between bare metal and DES. 76 patients in bare metal and 78 patients in drug eluting. Studied focal lesions of 18 and 15 mm length and severely calcified lesions. They, at 1 year, DES, which was Zion's stent, showed significantly higher primary patency compared to bare metal, which was multi-link vision. Their limb salvage rate at 1 year was not different. And the another endpoint, which is late lumen loss at 1 year, was also significantly lower for DES compared to bare metal. So another third major trial was Achilles study that studied up to 200 patients and compared Cypher stent to balloon angioplasty only. And they also showed that in Cypher's arm, their endpoint was binary restenosis. So the drug-eluting stent arm had significantly lower rate of binary restenosis compared to the bare metal stent arm. So all the studies that I presented, they show that in focal lesions, drug-eluting stent, they do better and have higher efficacy. There's a new study, Sawal study by Jihad Mustafa et al., studying a new dedicated below-the-knee stent. It is a nitinol self-expanding stent, crush-resistant scaffold, coated with paclitaxel group and paclitaxel drug, and it's made for longer lesion. Their standard size is 3.5 into 80 mm that they are studying. The results have not been published, but 301 patients with CLI were randomized. They made the study in 2 phases. The first phase, 201 patients with CLI, Rutherford class 4 and 5, they were randomly assigned 2-to-1 to drug-eluting versus PTA arm at up to 50 centers in United States, Europe, and Japan. And the second phase of the trial will be a non-randomized single-arm study of 100 patients treated with Sawal DS PTK. So it'll be really interesting to see what this shows. So also lately, bioresorbable vascular scaffolds have been studied. They have an advantage of delivery of anti-proliferative drug directly to the site of vascular intervention. They provide mechanical support like a conventional drug-eluting stent, and does not, because the stent resorbs, it does not preclude any further surgical revascularization. So one study that by Ramon Warco published in 2020, they showed their long-term results of everolimus eluting bioresorbable vascular scaffold in infrapopliteal arteries. It was a single-center prospective study of 48 patients with 55 limbs. They included patients with chronic lower limb ischemia with the Rutherford class of 3 to 6 that had more than 60% stenosis, less than 5 cm long in distal popliteal or tibial arteries. and diameter of 2.5 to 4. CLI population was 72% in this group, and severe claudication 27. So most of the lesions were mildly calcified, and 2 patients had scaffold thrombosis. So, okay. So they showed that before and after the intervention with bioresorbable scaffold, the patients with a lower Rutherford class claudication significantly increased. Their primary patency at 5 years remained at 72%. And there another efficacy endpoint, which was clinically driven target, freedom from clinically driven target lesion revascularization was 90% at 5 years. So, these guys also published a midterm outcomes of same everolimus eluting bioresorbable vascular scaffold. It was a pooled analysis of individual patients, the newest study. They studied 121 patients, and also from Rutherford class 3 to 6. Most 55% of the patients were Rutherford class 5. Total lesions, so 161 lesions out in 121 patients. Also the main focal lesions with a mean lesion length of 21 mm, target vessel diameter of 3.1, and on 22% of patients had total occlusion, and 63% of the lesions were calcified. So they showed that the freedom from restenosis at 24 months was 86%. And freedom from clinically driven target lesion revascularization at 24 months was 96%. Major amputation occurred in 1.6% of the limbs, and overall survival was 85% at 24 months. So with all this background, the few conclusions are that DEBs, when compared to PTA, they show non-inferior safety outcomes and only comparable efficacy outcomes. Sirolimus eluting stent and everolimus eluting stent, they achieve significantly higher primary and secondary patency rates at 1 year when compared to BMS, but the data is available only for focal lesions. There are currently no dedicated on-label DES in market for BTK. So everolimus eluting bioresorbable scaffolds, they achieve high primary efficacy endpoints at 24 months. However, currently there are no randomized trials available for them. So with that background, this new study that our center is involved in is a live BTK clinical trial that aim to study safety and efficacy of this new device called a Spirit BTK system for treatment of disease infrapopliteal lesions in patients with CLI. The device that is being studied is a drug-eluting temporary scaffold that fully resorbs over time. The backbone is comprised of 100% poly-L-lactide, and the coating is for everolimus coated balloon with a bioresorbable polymer. And they have 4 platinum markers for opacity. So the scaffold is fully resorbable. The strut thickness for less than 3 mm stent is 99 mm, and it resorbs in 3 years. The polymer coating provides sustained everolimus release to maximize long-term patency without any downstream particulates. And as you know, everolimus is a cytostatic drug, which is patented for restenosis reduction. And the density of the drug is 100 microgram per centimeter square. So the trial design is it's a prospective multi-center, single-blind, randomized controlled clinical study. 225 patients in up to 50 sites will be enrolled in US, Australia, New Zealand, Singapore, and Taiwan. Randomized in a 2-to-1 ratio of Spirit BTK to PTA, and the estimated follow-up will be up to 5 years. So the clinical status of this trial at this point that it's currently still enrolling. And just to go over the inclusion-exclusion criteria for that, we're including symptomatic CLI patients with Rutherford class 4 and 5. at least 18 years of age, and that required primary treatment of up to 2 lesions or restenotic intrapopliteal lesion. And the patients who has had any amputation to the ipsilateral or contralateral extremity were excluded. Patients with any allergic reaction were excluded, and patients on dialysis excluded. Subject or patients with significant infection or an extensive tissue loss that is salvageable only with complex foot reconstruction was also excluded. So this, so we will see how what this trial shows. I'm not sure when is it supposed to.
They're almost finished their enrollment.
finishing
Almost
up,
finished
so-
their enrollment.
Last 30
So
or
it's
so
very
patients.
interesting to see. Thank you.
Yeah, fantastic. That was a
Great
tour
job.
de
Yeah,
force.
it's
Oh my
great.
God, that was
Yeah.
awesome. So
Gave us
anyway,
just enough time.
yeah, really. Well, while you did all that, Roman and I were busy working. I just want to kind of go over what we did. So we crossed. I don't know if you saw, Confianza popped through. Lucky, just at the cap, and boom,
Stato,
it went
yeah.
right. Or Stato.
Yeah.
Sorry, it was a
Nice
Stato
job,
pop
Rama.
through. And then we were able to externalize the wire right here. And Raman was very patient working it. It's easier. It's tougher than it looks, right? It looks easy, but sometimes you just gotta. Well, I want to show it going. And then what happened was we rotated the catheter as we were rotating. Raman
PK, you really wanted Raman to work, huh? You didn't even turn the catheter.
No, he did. No, he was initially trying. He was initially, but so he was.
So you'll see.
And then he says, "Okay, let's
a little
rotate."
jiggle.
And
Helped
finally,
along the
Raman
way.
got frustrated. I'd say, turn it, and then you turn it. There you
Yeah,
go.
and then it popped right in. It was very nice. It was very nicely done. And then boom, I
Right
think he
there.
got in twice
That's it.
because he wasn't happy. And then he's like, "Oh, see, he pulled it out and did it again." So then we went ahead and externalized the wire, which is very important because you get the body floss. And what we tried to, then we were able to push the catheter from above, below, which is O1A, Terumo, Navicross, and then we checked our position, put a Spartacore wire down. And now the question is, now we can start the intervention. So we got 20 minutes to do the intervention. So we got the balloon across, all that wonderful knowledge that what Twinkle presented. Obviously, this didn't cross all the way. I think we have to balloon before we do anything. So we're going to balloon this with a 3-0. So we're just going to attach the 3-0 here and balloon this section.
So Vishal and Atul, in the meantime, so what are your plans
Go
of
ahead.
what do you think
Go.
we should do next? Atul, you want to take it from here?
Okay, good. Down.
Yeah, I mean, I think you got to figure out once you balloon it, you got to look at what are you in a dissection plane? Depends on how you entered. And I think you're committed to stenting in the end. But of course, I think trying a drug-coated balloon is a smart way to go.
Reasonable.
And if you get away with that, that's wonderful.
No,
But I have a
not
feeling you're going to have to stent somewhere along the way. And
So
I think
stent, you mean you're going to do a
Give us a
DES
coronary
on the
balloon,
top
guys.
and DS below also,
Balloon here,
or
too.
30.
what kind of stent would you use?
Balloon this here.
So I would use. I mean, I think below the knee, it's pretty straightforward. And Twinkle did an
Down.
incredible job presenting. I think you're committed to DS below. I don't think that's a tough concept there. I think above, you may be able to get away with ballooning, but I think an IVIS may tell you what you're dealing with in the SFA. But I'm a big fan of putting in Zovers now. I think, Zover or Illuvia, I think any kind of drug-coated stent, if you're going to stent, it's a better option than bare metal in the SFA. If you're in the POP and you have to stent in the POP, then I think we're all on the same page from prior cases that Supera is the way to go in that area. But I think you're going to have multi-level stenting, and I think that's going to be just the cost of crossing the CTOs.
Yeah, I mean, I agree with you, Atul. I mean, there's no data that shows intraluminal versus subintimal is better or worse. But clearly, we all want to be intraluminal if we can. It's more elegant. It's the way to go. But to spend that time without having the benefit of the patencies being improved, although Tepe had one paper that showed, intraluminal crossing, DCB was good in intraluminal subintimal. But the problem was they didn't have any IVIS to show you what you were. So it's very difficult to say you're intraluminal. But regardless, theoretically, it's definitely better, right? So I think at this stage, what we're going to do is we don't want to mess up the trifurcation. So now I'm going to need some dye to make sure I'm not in the trifurcation. So I'm going to have do a
The
DSA
calcium
shot here.
marks your.
Yeah,
What-
I just want
you
to.
have a
I
3
don't
balloon,
want to.
right?
Yeah, I don't
I
want to
think so,
close.
no
I don't want to close my the AT. That's one of the goals me and Raman had. See? Yep, one of the goals me and Raman had was not to close the AT. So hopefully we don't close the AT, and we can stop right at the So
Beautiful.
Yeah,
So
that
we're
calcium
sort
is
of-
your marker. if you want.
Yeah, we're a little bit across, but you think we'll plaque shift into the AT?
No, I don't think
we're
so.
Okay. All
I
right,
don't
go
think
on.
so.
We'll
There's
go
a
on.
nice, beautiful angle, so I don't think you will.
If not, we'll just get Doppler access to the AT and then wire it.
Yeah.
Go up.
Vishal, what is
No,
your strategy?
I mean, I think the whole, like Atul was talking about, you have to essentially
Mhm.
balloon the whole track to see
Got it.
how it behaves. For me, I'm more of a drug-coated balloon fan, so I would probably, I mean,
Wow,
I have to
sliding, man, I
layer
have to
the
go up.
whole
Yeah.
lesion
Go
up
up.
with drug-coated balloon, and then I'll probably see a spot stenting if
I got it.
there's a
Mhm.
lot of recoil, dissection,
10, 12.
and how it goes. I mean, everybody knows that putting in longer stents, whether it be
Okay,
any
go up
kind,
here.
alluvia, silver, or bare metal, as you start going towards the longer end
Down.
of the spectrum, the patency rate definitely
Go
starts
up.
to drop off. So
hmm
the idea is, of course, give the maximal advantage to this patient. And my goal will be to
Okay, I'm
balloon
gonna
all the
inject
way,
it so
drug
that we
coat
get
the
new
whole
flow.
lesion length so that at
Finish.
least there's some drug in there,
DCB.
and then decide
Injectable.
where we need to stent.
So you're going to drug coat. Let's say you drug coat, and then you decide to stent. Would you still use a silver or just bare metal?
Okay, so yeah, most of the times people say like,
Very
there
nice.
is no
We've
data to
achieved what we
suggest
wanted.
That
adding
looks
another
good. Yeah.
Pretty good.
another
I think we
layer.
can
Yeah, that
still
looks very
stent
good.
from drug
Mhm.
coat.
Another layer of
Yeah.
drug over
H1
already
reaction.
deployed drug.
Unbelievable.
I've not been
Okay.
hesitant to use it. Again, it's off
Okay.
the
Ready?
label
I'm
stuff to
watching this
use
out.
two
Mm.
drug
Give us
layers,
a-
but there is
a
nothing
5/0
contraindication.
long
People say you'll have some
peripheral
aneurysmal
balloon.
changes in the vessels because of extra drug. But if it's a
Yeah.
short, then I will not
Just
hesitate from
long.
using silver.
Hold
But if
1
it's a
4,
long, then
please.
probably do a bare metal.
Longest.
Longest.
So PK and Raman, what is your strategy in the room?
Well, you guys saw, like I said, Raman and I had very defined goals before we started. And one of the goals was not to lose the AT or the PT. And that's
Yeah.
why we talked about dual access and all that stuff.
And you didn't. Okay.
And we didn't. So we achieved one goal. Now the question is, let's balloon the SFA. So we're getting a 5/0 long balloon for the SFA
Perfect.
just to get it started. And then once we balloon the SFA, we're going to see what the flow is. and
Are
then
you going to
decide.
atherectomize the popliteal area or no?
We've got the atherectomy open. I mean, we may. I think we could use IVUS to kind of figure
Yeah.
out where we are. I don't necessarily. Again, it's another thing with IVUS. I mean, everybody's talking IVUS, and there's no data to tell us anything. It's adding cost. Of course, if you have an ambiguous in certain things, IVUS does help.
Yeah.
But I think to help direct your therapy, there's not enough data.
Exactly,
So I think
especially-
at this stage, we're not going to IVUS because I think Raman and I know we were very subintimal up top.
Yeah.
So we're
Right.
going to stent. We're going to stent the SFA. So
Right.
it's more about vessel prep now.
Yeah.
So we want to
So
prep the vessel and get the best expansion of the stent we possibly can.
So the way I'm
let's see.
looking at it, I think you are saying you're going to stent the SFA and probably DCB the pop and leave it alone.
That's what we'd like to do.
Yeah.
But
Yep.
I don't know if that's going to happen. Let's give a little data, make sure we're not going into
I think that's I think atherectomy
Yeah.
for just popliteal might give you some benefit if you
Mhm.
wanted to use a DCB PK. I
Right.
think it's because I know we might be in SFA is
back, yeah.
I think it's out of the question. We are pretty in subintimal. We know that.
Yep, guys, he's going to have pain. Okay, ready? Yeah, I
But I
agree.
think
So-
I think that's a great strategy because SFA is a really large vessel. So I think stenting the SFA and DC being the popliteal with atherectomy, I think would be a very, very reasonable option.
So
That's
we're
what I
going with
would
a very
suggest.
small balloon here, a 5/0 for this man. He's a large SFA person, and so what we're going to do is we just balloon it with a 5/0 at a high pressure to get the track open. That's probably
Interesting.
where we
Even
entered.
even 5/0 looks pretty reasonably big for
A
his.
little bit of pain, my friend.
But you're
Yeah,
probably
we're very
subintimal. on that side,
subintimal,
right?
yeah.
That's why it gives you that feel
Yeah.
that it's
Yeah.
not expanded. But yeah.
Yep. So we're going to go ahead and now we're going to go to the ostium now, down. Uh-huh.
Yeah, if you think that way, then you can lower down your costs a little bit. You can directly go with the DES up top, and then
Little dye twinkle so he sees the ostium.
and then just use one DCB and atherectomy for popliteal.
There you
That
go,
way
you
your
see the
cost is
ostium
down
there.
too.
A little more.
So Karthik, how do you
Okay, let's go up
compensate
there.
for the size mismatch? We see a lot of vessels
Yeah.
where the popliteal is a 5/0, 6/0, and suddenly it tapers down to an 80, which is like a 3/5 max. So now you, especially in this lesion where it's technically the lesion is right at the origin of the trifurcation or the AT and the TP trunk, I would say. So how would you account for that mismatch?
I mean, normally, if you're using a DCB, Vishal, I would probably go with a 5/0 DCB,
Serenator for
and then probably use a 6/0 balloon to post dilate my proximal popliteal,
But let's see.
so that you have a good taper.
Let's see.
That's what I would do. I don't know what would you
What's
do?
No, I mean, again, I would probably use. I mean, I'm again a proponent. Like, I'll probably use,
Okay,
and
so
like you
higher,
said, a
a little
5/0
back, make sure
DCB.
we're on the-
The idea of the DCB is
Now we
not
gotta
to
come
really
back
cause
a little bit
expansion,
more,
but to
maybe?
drug
Right
delivery.
there.
Yep.
And once you have the drug
Yep,
delivery in,
Then you
depending on
post
how
it.
it
This is
responds,
7/0
you want to
long
post out
balloon
to a
now?
6/0, you can do
Yeah.
a postal 6/0 with
7/0
any
long.
balloon you like.
018
so
or
usually the
014
strategy
balloon,
is
doesn't
that way,
matter.
which I completely agree.
The only thing which I'll say is that for the atherectomy of that distal pop segment, if you go with the Hawk system, your nose cone is going to dive nice and deep into that PT. And I think if one of the things we're really trying to avoid is to disrupt the tibial vessels, I think we may have a little bit of a challenge trying to atherectomize the full portion.
But I think the PT doesn't have any lesions. So
Yeah.
technically, if you feel resistance, of course, you stop. That's the first rule of interventional cardiology. But I think because it's such a robust and nice size PT, I don't think it will be a big
I think the
issue.
atherectomy is mainly for your entry point.
Correct.
And your
Nose cone shouldn't go up.
mid-pop segment, because so that you can get a good luminal gain
gain.
when you do a DCB. I think here is not to debulk, it's to get a more luminal gain than anything else.
You got the balloon.
Well,
I will say,
I think the other thing is, it's about, there's a whole theory about drug delivery. Drug delivery is improved after atherectomy, right? So conceptually,
I don't know if there's any data on that, but
well, there is one trial by Alazar Edelman, I believe, if I'm saying it right. He's such a incredible researcher. I don't want to mispronounce his name. In Mass General, he really one of our inspirational people in our field for the amount of work that he's done with drug delivery. But he had a study with CSI in the BTK that showed spinning actually increased the drug uptake. So that is the only study that we have, for what Atul was saying. But I definitely think that you're right, Dakar. I think there's really not a lot of robust data out there that can hang our hat on, So this is a 70018 balloon. It's an ultraverse balloon, great balloon.
7-0, wow. Okay.
Yeah, so we're really going to open this up.
It's a big vessel.
Yeah.
you want to see if you're at the distal cap?
You want to see the distal? Is that
we're just giving dye. Yeah, we're good. We're good there.
We're
All
good
right,
there.
little Delore, my friend.
What's nominal?
Little dollar.
all right?
one of the things we always talk about in the last 5 minutes is what is going to be the therapy after the procedure's done. And, we always end up with a rapid discussion. Maybe we'll start a little earlier. What are you going to give him after this, Raman?
So I've actually a little bit of pain, my friend. All right, if you can give us some more pain meds. I've actually, if I try as often as I can to get people on these Xarelto 2.5 BID, which missing out on any of the insurance issues. Usually, I've had the best success
How
with.
high did you go?
8.
Oh no, go to 12. So so I agree with Raman. I think we've started incorporating the data with Voyager PAD, and now we really need to expand this. So so you can see I'm telling Raman to go up really high. We're watching the heart rate.
12.
Okay, down. So now that's a 7.0 at around 12 atmospheres. It's a semi-compliant balloon, I'm assuming, guys from out there.
It's a nice expansion.
Semi-compliant or non-compliant?
And I think the entry spot opened up well on the second inflation. So where you re-entered back into the lumen. So I think it will.
So Raman's going to walk it back. We're going to hit the ostium as well one more time, and then what we're going to do is we're going to go ahead and then decide. Like I said, I completely agree with Atul here because our final therapy is going to involve a stent. The only question is that stent?
Huh?
Semi-compliant. Come forward.
Oh,
Did we balloon the popliteal? Not yet, right?
Not yet. We just did a 3-0.
Okay.
So ready, little die, just to make sure. Too far, right? Maybe not.
Yeah,
Let me
a
see.
little too far. You can go down a little bit if you want.
How about
A
now?
little
Raman?
too far into. Little bit.
Yep. Your Karthik
way.
has got eagle eyes.
Yeah, but it's a nice
Okay.
profunda, right? There is no reason to shift into the profunda.
Oh, there's
so
no question, Karthik.
Yeah.
I mean, you kidding?
It's a huge
Definitely.
CFA.
he was living off of the profunda for
Yeah.
Yeah.
all this time.
I think this guy we can, and the angle is very favorable. We can definitely nail the ostium. So
Can I
Great.
ask you why
No
our
pressure, Raman.
kidney is so bad? Our fluoro is so bad.
I think
you're on low fluoro, which is fine, PK. I mean, it's good.
It's fine for young guys like you, man. I mean, guys like me. I mean, it's.
We're doing cases in that room, and we're only doing like 100 milligram for complex interventions, which is great.
I know. That's definitely true, but I think that's the reason
12 again.
you and Vishal don't fail because you don't see your failures.
That's a low blow. You know that, right?
Listen, you set yourself up.
The day
Hello,
never
Vishal.
ends.
You said that.
See,
The live case cannot.
texted me that one.
I know
Atul just shot me a text. He said,
I know
"You
the
got it
live
now."
case cannot end without PK showing a
that's what
low
I'm saying.
blow on Vishal and Karthik. You know,
I mean, listen, it was Atul. I'm blaming Atul. He sent me a text.
The day
Atul
never-
doesn't do these kind of low blows. I know Atul very well. Atul is like quietly sitting in
I only
Queens.
hit, I
He's
only hit
happy there.
below the belt. PKH below the
Excuse me. Okay, we're gonna do a quick DSA now. So this is when you have to watch out for Hiroshima.
Off flow.
Huh, Cindy? So
I
hopefully
mean, he
we don't
didn't
have a
complain of
Hiroshima.
much pain, so I'm assuming there is no Hiroshima here.
Wonderful.
That's
Beautiful.
sensational.
Very big vessel. We're very happy with that. Now let's make sure here, you know.
I thought you were saying wonderful because now you have no choice but to stent.
Well, yeah, of course. Yeah.
Yeah.
Oh, I agree
Now,
with you.
now it's an easy decision.
Now it's well, I think Atul, I mean, you and I had made up our minds. You know, we were going to stent this. I mean, there's.
I know Vishal was hoping to lay down some drug balloon.
We can't come any lower.
Vishal, what do you think? Now you'd have to stent, right?
Now you have to stand, yes. Like I said, I mean, listen, you have to keep evolving on your strategy depending on how it is.
Yeah.
We had to aggressively balloon dilate the vessel, see how it
Yeah.
responds, and go from there. So,
Atul, at Sinai, we are overly optimistic. We always feel like we can get away without stenting. So
we need to stent. So, okay. So outflow is not good. Now let's talk about the pop. What's the plan?
I
know
would
what I
still
wanna do.
stick to atherectomy and DCB for this one.
All right.
do a
So,
atherectomy and then do a 5-0 DCB,
5-0 DCB and then
we'll
6-0
see how it goes.
6-0
All right,
If you
guys,
proximal.
give it-
stand with the Supera, that's fine.
all right, guys, give us an
First I
EXL.
have to- Shouldn't we pick what kind of
So
athletic?
since we already
One second.
have the M open, you want to try a Serenader here? We've had some pretty
Yeah.
good results.
All right, give
with-
us a
with-
Serenader. Let's try
Yeah.
a Serenader. But you
Do
know,
a
that's another
5-0.
thing. You're adding costs. I mean, like, what are you trying to
Yeah,
prevent?
exactly.
Are you
Right?
trying to
Nothing.
prevent
We have to
stenting? Is
stent
that
it.
it? I mean,
Yeah.
it's not. I mean, you think a Serenader is going to reduce your dissection? There's no data that shows that.
No,
So
I
to
don't
me-
think so. I think atherectomy and DCB and
Yeah.
just plain ballooning
That's
is
it.
enough.
Yeah, I
That
think
will
we're
give you an
gonna-
idea. I mean, if you end up with the
EXL.
dissection plane, you
So
just
guys,
put a
I'm going to go
super.
very conservative. I'm going to go with an EXL because we were subminimal, and then if we have an M, if we need to go with an M. So I'm going to have Raman just do the EXL while we talk to Twinkle. So Twinkle, knowing the data, now you know the data. You're the expert in the room. Okay, so I know these kind of multi-level cases have not been studied, right? So in terms of lesion length, this has been studied, right? It's about if you just take the tibials or the so that pop, in my opinion, is no bigger than a tibial. It's the same
Right.
size as maybe a 4-0 at the most. So
Right.
the question is, what do you think the data supports us doing in this particular case?
Well, like you said, I mean, we do DEBs routinely, but then there is no data that the DEBs are superior to stents.
Mm-hmm.
When it comes to stents, like stents have only shown higher efficacy in focal lesions.
Mm-hmm.
So
And
this
focal
is-
was defined as
focal
what?
is like a
30.
the 30 is the maximum, the
In the study.
longest
Mm-hmm.
lesions
like the
that
Serenade.
that I saw. So
But
I
we're
mean,
really
so
flying by our pants.
we don't really know, but I think, I mean, is probably like a DCB, and then if it's probably a Supera to.
Okay, so we have one vote for DCB, bailout Supera. What about you, Atul?
I'm not going against the expert in the room.
What about you, Karthik?
I in generally don't go against women at all. That's a rule. It's my rule. I just don't go against women. Period.
No, but come on, it's all
So
seriousness.
yes, I'll stick with Twinkle. I'm
Okay.
very smart guy, so
What about you,
I'll stick
Vishal?
with Twinkle.
No, I think I agree with the plan. I mean, listen, we know the data on Supera is good, especially, I mean, for lesions around the popliteal and calcified lesions. Atherectomy definitely will help do plaque modification there.
Mhm.
And the idea is to try to do DCB and see how much is the gain. If you have a dissection, we can Supera it. Otherwise, just do an atherectomy DCB and leave it. I mean,
Now,
we've seen
I
good
also
data
went
with
very
this.
conservative on my atherectomy because I don't want to create a
Correct.
perforation.
Yep.
So
Right.
all those of you who don't do popliteal atherectomy, it's very important to undersize your device and just do two passes. Do not
Two
do
cuts.
4
Yeah.
in the popliteal, please. 2 opposite wall cuts is very, very important. I do not do 4, a little higher, Roman. From there. I do not do 4 cuts. It's very important because obviously if you perforate this, depends on the level of the perforation. We have also put in, we stacked Superas to
Right,
really
front.
compacted them, and I've stopped perforations in this area because it's not a really great area for a covered stent.
Right.
But it is what it is. I mean, you either if you're on the pot, you gotta go, right? So you gotta go now. So we gotta
Off.
do this. So off, and then now we're gonna take a picture. I want to IVUS now for vessel size because I want my DCB to be appropriately sized so I can choose the right Supera if I dissect. So can I get a quick IVUS, please? Yes, thank you.
I got wire. DSA?
So we're at 9
Yes.
o'clock, and this is a multi-level case. We're not gonna. We'll continue recording and after we come off the air, after we take care of this, and we'll stent the SFA and show a final picture. But I'm just letting you
so
guys
PK,
know.
Raman, you didn't cut the entry point.
Yep. We're gonna have to go back and do a couple cuts at that level.
Yeah, because you got a good result just with that atherectomy 2 passes, right?
Yeah, so we're gonna do it a little bit higher up.
You need to prep this.
Right. I mean, I guess my only thing is, PK, we still haven't really dilated our popliteal vessel more than an arterio.
Agreed. And what I'm going to do now, Vishal, is do an IVUS for that reason, because I don't want to dissect this.
We're almost done, my friend.
I would assume that the vessel is much larger.
Correct.
Because of the SFA size.
Right.
But at this stage, I mean, listen, I want to size this properly. I don't want to create issues.
Yep. Yeah, because PK, just with atherectomy, your distal vessel looks pretty big.
Yeah. It's a
yeah.
Well, his AT is very, very big.
Yeah. Exactly.
Yeah, that's what I'm saying. Just with atherectomy, the distal vessel already opened up so significantly.
Right.
I'm assuming it's at least popliteal is at least 6-0.
Just do one cut, Raman. I don't want to be crazy aggressive.
No, it's okay.
There.
I think
no, because it's bigger here.
Yeah, it's very big there. You can definitely do EXL.
Even do
you can 2 cuts is absolutely 2 is.
We're just going at like this is like distal off.
Yep. Let's do the IVUS now. Again, guys, I mean, let's talk about definitive data, right? I mean, with atherectomy as a final therapy, we have very poor data at 1 year.
Yeah.
The SFA pop.
78%.
It's respectable, but it's 1 year and it's not compared to anything else. So I prefer that, we don't cause a complication. Like, okay, we want to prep the vessel. I agree. And now we're going to IVUS it to size it. And then we'll go with an appropriate balloon. And if we have a lot of calcium, a lot of something like that, then we'll just do a serenator like Raman suggested, or we'll do a pre-balloon followed by a DCB. Good, excellent flow. So now we're going to go ahead. Let's go ahead and do the IVUS. IVUS is on the table.
So I guess you're right. I mean, for the viewers, the strategy, like PK was talking about, using IVUS and adding the additional cost, in this case is justified to get the luminal size, not about, like PK said, determining intraluminal, extra, subintimal. That is out of the picture because we've already crossed that path. But here in this case, IVUS is definitely a good, what you may call it, another additive information for us to really make a good educated decision,
but
especially with DCB.
Yeah, but I think PK, IVUS is definitely completely reimbursed. So I think it's reasonable to use IVUS when it's necessary because it's reimbursed.
Oh, no question.
And it gives so much more data.
See, okay, ready, guys? It's not as big as we think. Ready? So going a little further in, Ray. So this is the posterior tibial, right?
4.
So posterior tibial is about 4.
4.
Pull back now. Record. So, while Tinkle Fluoro's Ray's pulling back, and you can see here.
It should be in the pop.
That's still the TP. That's still the TP trunk, right? Now it's the pop.
So 1.
Okay, freeze all this, guys. Take a picture here. That's a good picture. Okay, mark this.
5.
Yeah, 5-0.
Mark this.
5.
I think it's a 6.
Yeah, now it becomes a 6, right?
Mark
at the distal.
More approximately a 6.
Once the ostium is going to open up, yes. Now it really
now we're
clears out.
Yeah, now it's huge.
Now, yes. So it goes from like a 7 to a 5.
7 to a 6. That's what we have to assume.
Yeah, so probably use a 5-0 DCB and 6-0 proximally to dilate the entry point.
Yep, we're out.
Like take a 6-0 wire track or something.
Get us a 5-0 long DCB, please. 5-0, 5-0 60 or no, actually 5-0 100.
No, yeah, 100 is good.
Stop recording.
The problem is with these Medtronic DCBs, we have a lot of data with the Medtronic DCB, but the deliverability of the DCB is not exactly fun. The SFA is completely dissected, you can see. But we have a lot of plaques, so it's got to be stented. So we're going to stent the SFA.
Let's do 120 then.
5-0 120. We don't have an 80, of course. So
we have 80.
We do have 80.
Yeah, you want 80?
Oh, no 100 though.
Yeah.
So 120 is fine.
Yeah.
120 is fine. It's just going to float in the SFA anyway, so it's okay.
So we're going to do this now, and the idea is going to be where you're going to extend the balloon into. We have the IVUS person here. Can you just measure the pop for me, and tell me the size for me, please? Oh, our other IVUS person is here too, so we've got a lot of IVUS help here. So I need to know the distal pop and the proximal pop. So guys, I think what we're going to do is once we show you the results here,
right?
What the SFA is just basically stenting, and I don't want to take up your time. What we're going to do is we're going to have our wonderful AVP team continue recording us as we do the SFA, and then we'll do a final shot of the whole thing. But we'll sign off so the audience can get back to work, because we always try to do within 1 hour. This is actually done pretty nicely within an hour, but obviously the decisions are going to take a little bit longer. Hopefully we can finish this as an hour and a half. And since SFA stenting is, pretty much mundane at this stage, you saw us prepare the vessel very aggressively with a 7. So we're probably going to go with a 7.0 Silver or maybe a 6.0 Silver, depending on what we decide. We do have IVUS, so we'll IVUS size it, and then we'll go ahead and do it. Here we have to deploy a Supera. I think it's nice to show that online, so just hang in there for a little bit. Obviously, we're going to have a 3-minute window where maybe, I can tell you
as you said,
I can tell you some jokes. I can tell you some jokes.
PK, I think we should go ahead with the discussion. So,
jokes.
Listen, Raman likes my jokes. He always laughs at my jokes. Okay.
Raman has to laugh on your
Yeah,
jokes.
because the joke is not on him. The joke is on us.
The joke is on me and Vishal. So Raman has no issues with that.
Not going.
All right.
Same problem, guys. Not going.
Yeah.
All right. Let's.
Going to exchange out for OT5 wire.
Probably.
Let's change out for an 035 wire. Huh?
Probably dilate it and then put the DCB back in.
No, I think an 035 will give you support, and you can put the stent on the 035 wire as well. The
All right, give us a 5015 via track. So we're going to balloon it with a 5 on an 014 wire.
If you put the drug balloon in the body already, it's gone now.
No, that's actually not true, Atul. I think that's a great point that you brought up. So the myth is that it's gone, but remember you have the coating is only 20%. 80% is in the infolds.
Infolds.
So they actually account for the loss of the 20% during transit. So you don't have to
unless you inflate it, it's not.
Yeah, exactly.
Right. Okay.
So, I don't know what happened.
No, that's good. That's a very good piece of knowledge. I was always under the impression that once it's touched blood, for
no, it's not. I mean, you do have some. You do have about 30% loss, but you can get at least 60 to 70% of the drug once you inflate it.
So basically, Karthik is right. The math is 15 to 20% lost in transit, 70% delivered,
right there.
And then 15 to 20% remains on the balloon as you pull it out.
Yep.
So it's pretty much an unequal 100, but that's kind of how it works. So now we're going to balloon this with a 5, and this is going to tell us a lot on how this balloon. This is a renal balloon called Viatrac, and so we're just going to balloon this. It's an 014 monorail balloon, which was very, very, very how can you say trackable, and so it's a lot of fun. So
PK, as you said, like this case, 1 hour to complete this case. I mean, I think we are talking and we are doing a lot of discussion here, but completing this case in 1 hour is a pretty successful completion. For a complex case like this, 1 hour I think is pretty short time.
I'd go distal to proximal.
Yeah,
I agree with you, Karthik.
Crack it, yeah, good.
Just don't get into the TPT. Little die, guys.
It's
Can I bring up a question from the audience?
Yep.
So what is the risk of ISR when stenting the false lumen of the SFA? Why not simply use a DEB for the SFA?
Excellent question. So the CTO cohort of the impact SFA study. The impact SFA. What is it called? What we call as imaging cohorts have shown that DCB does work in subintimal crossing for CTOs. That did result, especially the long lesion cohort, resulted in 40% stent rates. So the true answer in terms of ISR for DES, we don't know. That's probably the true answer. There's no study that's looked at DES ISR in the subintimal plane. That would be a good way I think that's a good answer for us to look at our data and see what it is. He's having a lot of pain, right?
And I think, PK, just to add to it, I think, theoretically, Atul, the question is, we are in such a big lumen that there is a lot of recoil in the vessel. No matter what kind of, we use a 7.0 balloon, and there is still areas of recoil. So unless you put a scaffold, I don't think you're going to get the best result. If you do an ultrasound with this result by DCBing it, 3 weeks later, you're going to see like tripling velocities in the SFA. You're going to still have a huge gradient in the SFA. You might not have a CTO, but you'll still have a gradient, and the patient might recoil significantly. Well, that's the point here, right? The vessel is calcified. I think scaffold adds more of a patency to me. That's what I theoretically I'm saying. I don't think there's any data behind it, but It's a
See,
theoretical thing.
the only question I'm concerned about, Atul, is here right after that collateral. I think that area might need to be stented with a short stent. You know, maybe just to help us keep that inflow
Keep
into
that
the
inflow.
popliteal open.
Agreed with that, VK. Yeah, I think
so
so.
let's
So I think
do
that
the
re-entry
DCB.
point, yeah, there's an re-entry point of that
Yeah,
wire.
you can probably put a
short
shorter,
supera
supera right there.
Yeah, we can put a 6.0 supera there, and then just leave it like a 6.0
Or,
40, and then
or you can do
just,
5.5.
I think 6.0 is good here. No.
Yeah.
I mean, for the vessel size, you just
For the
want an
vessel size is
elongation.
only 5. Vessel size is only 5.5, VK.
You can use
Well,
a
I think
6.0
they-
what was the
balloon.
vessel size at the proximal edge of the marked one?
They got 5.0 actually.
5.5.
Huh?
They got 5.0.
At the proximal pop, right after the CTO.
Well, right before the CTO.
No, the one before this.
Yes.
The one before this, you can go to the second
Right,
one, the
but-
second bookmark.
Yeah. We'll change it over the wire.
No, the second, right? No, the second bookmark from the top.
You have a new Spartacore?
You have to go up. Whoever is doing the IVOS, yeah, that bookmark. Yep, that's the one.
Yeah, it's a 5.5.
5.5.
That's
5.5 vessel. Okay. So 5.5 vessel, we'll put a 6.0. A little more.
A little more, yeah.
A little more. A little more.
Right with that calcium.
A little more. The
nugget is.
calcium is the key.
Just
Yeah,
before,
I would
above the
stop there.
calcium.
Yeah, that's pretty good.
Mm-hmm. All right, let's go.
This is a
Let's go up
5.5,
and then-
120.
Good. All right, go up with the balloon.
I think we're actually in the PT here.
Yeah, I would probably pull back a
No, I
little
think-
bit, Raman. I agree with you.
Yeah, the
Probably
CT,
at the
calcium.
beginning of that calcification, you can pull back.
Yeah.
You can even pull back a little bit more. I think it's fine.
Right.
Yeah, right there would be good. That's
Perfect.
good.
That's
Perfect.
But also, this is very important because the audience has to know that the balloon is going to have a lot of overhang.
Yeah.
So you know you are going to go into
That's
the
why you
PT
have to
in this
pull back.
case, so you have to pull back a little bit. But
Back
even
in
then,
like another millimeter.
it's going to have a lot of overhang. So let's see.
Yeah.
Yeah, right there.
Yeah,
Go
it's
up now. I
Yeah,
like
right.
That.
That's a good one.
That I
At
like
the
a lot
beginning
better.
of the.
One second, hold on.
So we're going to go up with this, and obviously we're going to watch paint dry.
And again, here you have to watch for Hiroshima if you have anything. So you have to make sure that the balloon is on the wire.
See, that's
So-
the lesion distally
Yeah.
that had to expand. And I think it's expanded
nominal.
well with the fiber balloon.
8.
That's a
Nominal
good
is what, guys?
expansion. That's a really nice expansion,
Nominal is
Raman.
8. Yeah, it's a very good expansion. We're very,
Very
happy
nice
with
expansion. Very nice expansion.
it. We're very happy with it. So hopefully we'll. Now
Very-
we have a timer on.
Yeah, very, very concentric, not an eccentric expansion. Very nice.
Yep. The wire's in the middle of the vessel.
Yep.
All those good things. So now we're gonna just watch this, and then if we're happy with this, we're gonna sign off, and then we're gonna offline, but it'll be recorded by our team. We're gonna go ahead and stent the SFA, and then we'll have the final result up. Now let's talk about anticoagulation. Okay, let me give you two different things, Raman. You're the doctor, obviously, of the patient. So if you put a stent versus just doing a DCB, does it change your anticoagulation strategy? And that's question number one. Drug eluting or non-drug eluting doesn't matter when it comes to a stent, and DCB obviously is a DCB.
I think for the if you leave metal behind, there's a higher there's more data to support at least DAPT. Voyager was also looking at use of Xarelto. So if you want to include the NOACs in that conversation, the low dose NOACs, then you can also support that. But DCB studies, I think it's a little bit variable. I think you'll see people using just like a single antiplatelet agent or two, but the timeline and the time course of the antiplatelet agents used for those is also quite variable.
Right, but as per the label, it's 3 months of a dual
Correct.
antiplatelet therapy. That's
Yeah.
very
Yeah.
important.
Yeah.
As per the label, you're right. Operator individual variation is there. The one question is, Twinkle, maybe you could talk a little bit of Voyager PAD. There's a increased bleeding risk after a month, right? If you have triple therapy, they do recommend triple therapy for a month and then go aspirin and Voyager, aspirin and rivaroxaban. So I mean, is that what we've been doing here? Are we doing aspirin rivaroxaban? Are we now switching it to Plavix rivaroxaban after 3 months? After a month, I mean.
We've been doing aspirin and Plavix
Plavix and
and
rivaroxaban, which is
yeah.
interesting because with Plavix there was a little bit more associated bleeding.
Correct.
So you know, it's one of the, you know, we haven't seen it in our cohort, but because again it's sort of like the high risk vascular patient and the low risk vascular patient and the high risk bleeding cohort, and you kind of have to marry the two together. So it's very important for the audience at this stage because these aren't on the guidelines. You got to be careful. You know, you got to know who's a high risk for bleeding, who's not a high risk for bleeding, because when you do something off label, and it's important to have joint decision making with the patient, making them understand that you're doing something that's not on the guidelines yet, but you have data to support and what your logic is.
Again, in the last 6 months, I've observed, I don't know what changed, but I don't know if COVID has changed something. I have seen a lot of bleeding, I mean, increased amount of bleeding risk for triple therapy, even in the first 1 month.
Well, bleeding risk triple therapy is, in the first month.
In the first 1 month. So I'm actually, unless I'm putting a medal, if I'm not leaving anything behind, I am not giving aspirin. I'm just giving Plavix and rivaroxaban.
Right. So
I'm just giving dual therapy. That's all I'm doing.
I guess the biggest question arises is when patients have concomitant CAD and they have a stent. Now you're committed to aspirin and Plavix anyways because of a coronary stent. Then what you do is the real question is, do you still continue triple therapy, or because of the CA, even if they have CAD, do you cut back on one of the antiplatelets and continue rivaroxaban, or just forget about rivaroxaban altogether?
No,
that's the biggest thing.
Yeah, I think if you have concomitant CAD and they've also undergone PCI, I think the data is still widely in favor of, you know, even all the long-term data of. Well, I guess, Joe, do you mean like a full anticoagulation dose, or?
I mean, the aspirin, the baby aspirin, the Plavix, or Brilinta plus Xarelto 2.5.
2.5, yeah. So
so we're gonna keep the like Dr. Guja said, keep it in the SFA. PSA, please.
So I think you got to take. I take each case at a time. In this case, I think you have multi-level CTO. You're putting in stent. Hopefully, just stent the SFA. But I think with what's going on in the pop, I would definitely use aspirin, Plavix, and 2.5 rivaroxaban for at least a month. I would consider more like 3 months, assuming that the bleeding risk is low.
Not to move. Sorry, Atul.
And I think the bleeding risk assessment is the key here, right? And Raman knows the patient the best, and can get an idea of that and understand, what is his history of bleeding.
The enemy of good is better here. So, guys, I think we're done with the pop. I mean,
I think so, PK.
Yeah, I don't know if that's a dissection or there's a vessel going across distally. Raman and I will do a quick IVUS offline, but if we do a stent, obviously we'll show it. But I doubt we're going to leave it because we doubt we're gonna what is it called, stented, because I want to tell you about our data, which we've presented at TCT. It's being reviewed for publication. So the modes of DCB failure, dissection is not one of them. What's the most important mode is recoil. So recoil greater than 30%, which we don't have in this particular vessel where we applied the DCB, clearly is not happening. So I'm going to trust our data, which is solid data from the randomized control trials and from the core lab adjudicated registries, and we're not going to stent if it's not flow limiting. But we will do an IVUS to make sure we have a 5.0 lumen, and we'll stop there. Rest of the SFA, Raman, Zilver, right?
All the way up.
So we're going to Zilver the rest of it, and then we'll send you the final photos. So Karthik, Vishal, and of course Atul. Thank you so much for joining us. And what we'll do is I'll sign off from here and thank Raman for such a wonderful case, and Twinkle for such a great presentation. Obviously Ray, Jen, and obviously our team Cam and Liz and Damien. So you guys can go ahead and sign off, but we are going to stay recording. Okay, team? The team.
Raman, great job. Okay, Twinkle, great job.
Thank you.
Thank you, guys.
See you next month.
All right. Thank you very much for a great case. Thank you, Atul. Thank you, Karthik. Thank you, the viewers, for joining us. For people who couldn't make it, unfortunately, because of the busy schedule, don't forget to log onto the website, ccclivecases.org. Under the peripheral tab, you can see this case and any of those previous cases in the archive section. Our next case is scheduled for April 27th, which is the last Wednesday of the month. So till then, thank you very much. Have a good day, week, and a month ahead.
Thank you, guys. Thank you. All right, guys. So just to fill you in on how we finish up the rest of the case. So regarding the distal popliteal, we did a prolonged DCB, and after the IVUS, we saw that there was a pretty impressive dissection plane at the proximal portion right where the vessel had totally occluded. So we treated it with a pre-treated it with a 6.0 balloon, followed by a 5.5 supera, really covering and trying to stack as much as we can right at that distal constitution, and it looks quite good there. And then atherectomize the prox and mid portion of the SFA, followed by a 7.0 balloon. Sorry, a 7.0 Zilvers 140 times 2 and a 60 times 1. And although, you know, we were discussing regarding, you know, earlier on what one of the issues regarding the large subintimal planes, and we do see that there were some areas in which, no matter how much post dilatation we did with short 7.0 balloons at you know, nearly the rated burst pressures, there are a few areas that still were withstanding that at a high pressure balloon dilatation. So, and it's, you know, granted that we just tried to avoid, you know, any complication here. We have excellent angiographic results. With our final picture, we decided to call it a day. And we see that the SFA is widely patent, with a few small one small segment that really does not really responding to recoil. And now we have impressive, robust flow was so fast we didn't catch it in time. 2.5 of that, you know, with that peroneal is that diminutive vessel, but a large AT-PT going all the way down to the foot. And you know, this guy's going to do quite well. And we'll put him on aspirin, Plavix, and Xarelto 2.5 BID. Probably stop the Plavix if there's any signs of any over bleeding or anything along those lines. But again, thank you again for joining us today, and thanks everybody in the room today for an excellent case. Thank you. Bye-bye.